Welcome everybody to the launch of the radiology GIRFT report. Absolutely delighted that so many of you have made the time to attend, and we're delighted that so many of you are interested in our findings and the report. Just a couple of housekeeping issues. First of all, to introduce myself, my name's Kath Halliday. I am the GIRFT lead for radiology. Secondly, to say that we've got quite tight for time today. We've just got an hour and we won't keep you more than an hour. If you have any questions, please type those in as you go along into the use question and answers rather than the chat if possible. And we'll try and answer as many of those as we go along. We do have 10 minutes for questions at the end. If we don't get around to your question, don't worry, we will still try to answer it after the event. So please, any comments or questions, just put them into the Q&A. The meeting is being recorded, and that recording will be available later, just to let you all know. So it's my great pleasure now to introduce the chair of the Getting It Right First Time programme and instigator of the whole programme, Professor Tim Briggs. Thank you, Tim.
So thanks, Kath, and welcome everybody. And it's great to see 370 participants already on the call. As many of you will know, the GIRFT programme had very humble beginnings in orthopaedics, but since then has expanded into 44 work streams, and we will be producing 38 national reports by mid-July of next year. Prior to the first pandemic, we produced 10 national reports with another 6 in the pipeline. So diabetes and the radiology report we're discussing today are the first 2 to come out post the first wave of COVID. I think this report comes at a critical time of the pandemic, and we've already seen that the NHS has undergone profound change. And as we try and establish our services, there is quite rightly a real focus at the moment on diagnostics. We know that radiology, doesn't matter which specialty you're in, it's vital to almost every specialty and every part of the NHS. And for me, it's pivotal that we make sure we have the highest quality and effective care from radiology, and we can provide timely care for our patients. I think the vision of the national report is a very positive one for change, making radiology patient-centric, which will include faster access to imaging, but also seeks to make the service more convenient for patients and also access as well as freeing up capacity, reducing unwanted variation, and also reducing procurement costs and litigation. So I want to really thank Kath for the drive that she has shown in 102 trust visits, and with the support of Giles Maskell, next past president of the Royal College of Radiologists, and also the help from Elaine and Lucy Bealey. And so with that, thank you to them. I'd like to hand over, please, to Professor Sir Mike Richards, who will just talk us through the current state of diagnostics in England. Mike.
Thank you, Tim, and thank you to everybody for participating, and thank you particularly to GIRFT colleagues for their fantastic report. And I will want to show very briefly how this links with what I've been doing more broadly on diagnostics more in England, and to thank them for their help with my report. So I published a report about a month ago on diagnostics, recovery and renewal, and which some of you will have seen. That report covers all aspects of diagnostics: its imaging, its pathology, its endoscopy, its physiological measurements. So it's broad, whereas I think the GIRFT report goes deeper in many ways, because I was not able to do site visits, which you have done. I could have guessed that you would comment on space issues, because in my previous work with the Care Quality Commission, I saw the space issues in many imaging departments. And of course, I wasn't able to go into the patient-centered issues that you have done. But there are lots of overlaps and areas of mutual interest between our 2 reports. Firstly, I think it's true to say that diagnostics has been something of a Cinderella. Everybody needs imaging and other aspects of diagnostics, as Tim has said. So why hasn't it really had the attention that it deserves? We can debate that later, maybe. It is vital for almost all areas of healthcare. And demand has been increasing. And it's been increasing particularly in CT scanning, MRI scanning, ultrasound, much less so, for example, in plain X-ray. In fact, plain X-ray almost gives us the background level of what is just population growth. And frankly, capacity has not been keeping pace with demand. So that is both in terms of equipment and most importantly, workforce as well. And so even before the pandemic, we were reaching a tipping point. And why do I say that? Well, because waiting times were getting longer, and that's both for acquisition of images and for reporting. And they would have been even longer still had we not been outsourcing. And so outsourcing, again, both of image acquisition and of the reporting. And then along came COVID and has just made everything much more acute. I think it has had the effect of saying diagnostics is now in the center stage. Everybody recognizing that the need. The regions are working very hard, that the demand is coming from there, not top down me saying it's just important. So what has my report recommended? First of all, of course, it has recommended that we need more capacity. You will know that we have the lowest number of CT scanners and MRI scanners in the developed world, roughly speaking, per head of population. So the international comparisons are clear cut. The reason I mention those is that's one of the easy things to measure across national boundaries, but it also applies to workforce. So we need to increase capacity. But, and I think this is important to say, we need to do things differently as well. And my report, one of the main things it recommends is that we should separate what I'm calling acute diagnostics from elective diagnostics. In other words, the diagnostics required in A&E and also for people on the wards from the ones requested from outpatients or by GPs. And that streaming, I think, will lead to increased efficiency. It will lead to improved patient experience, all sorts of advantages, and will be easier to keep free of COVID. And I was delighted to see the words in the GIRFT report, the ideal solution would be the creation of community diagnostic centres. Thank you, Kath, for that. We are on the same page. So in terms of acute diagnostics, if we could have better diagnostic services for A&E, we would have more same-day emergency care. That would, of course, save money, not necessarily in radiology departments, but it would save money in the system. Equally, on inpatients, across the country, only about 60% of CT scans requested on inpatients get done on the same day. 20% get done the next day and 20% further ahead. If we could get them all done on the same day, as we do with plain X-rays, we could save lots of bed days. I actually estimate that we could save over £200 million worth. So that might actually go quite a long way if it could be redirected to what we want to do in terms of building the workforce. Difficult to do, of course. And it's also, I want to say we really need to push the skill mix agenda. I found it, you have found it, very varied across the country. There's all sorts of things we could do more with support workers, and then we can also do things with advanced practitioner radiographers reporting X-rays. It's hugely variable across the country. To do that, we need to form networks, we will need leadership. So the easy part is writing reports. It may not feel like that, but I can assure you it is. The difficult part begins now. It's in implementing both of our reports. So let's turn our focus to that next. Thank you very much.
Thanks so much, Mike. We are so grateful to you for your report and for bringing the focus onto diagnostics. It's so valuable to us. And as you say, there are tremendous synergies between your findings and ours. So now I would like to go on and we will just talk about the recommendations in our report. And it'll be quite a whistle-stop tour, but as I say, any questions at all, bring them up, things that you think we need to concentrate on, bring them up in the Q&A and we'll attempt to answer those as we go along. So appropriately enough, we've started our report with recommendations around the patient. Let me just share my screen. Here we go. Is that sharing, everyone? Good. Okay, so our first recommendation is that Trust should review facilities and processes to ensure that patients are safe and are treated with dignity and respect at all times. As Mike has alluded to, radiology departments are too small on the whole. And the result of that is that waiting rooms have been compromised. We have seen inpatients, very sick inpatients, waiting in corridors, waiting in crowded rooms full of outpatients, their relatives and children. And it's really unacceptable. Trusts on the whole are doing whatever they can, but we would urge people to consider this as much as they can with local solutions such as curtains, for instance, can make quite a big difference. And also, of course, when anybody's building a radiology department, this really needs to be taken into consideration. My personal concern is always with pediatric patients. I'm a pediatric radiologist, as you know. We've seen departments doing amazing things with tiny spaces due to using charitable donations to make fantastic little areas for children. Just because a department is not a big children's hospital, it doesn't mean that it doesn't that it can't look after its pediatric patients. There's huge variation in what trusts do, but we would urge people to consider this in all their departments. Luckily, there is good guidance on how to build a new radiology or department or refurbish one with the building note on facilities, which is available to everyone to use. And of course, when we're thinking about patient facilities and facilities for relatives, it's really important that we take patients' views into consideration. Now, this is actually not as easy as it might sound. In radiology, it's quite difficult to gather patient feedback because we're often seen as part of the sort of wider patient journey. And things like the family and friends test don't often give us radiology-specific feedback. But we have seen some departments who make a real effort to collect patient and carer feedback and who've made really huge changes as a result, which have been very, very beneficial. Moving on. Concentrating again on the patients, imaging should be arranged at a time and place to suit patients and to ensure their safety. This has become even more pressing, particularly the safety aspect recently. There's a huge amount of resource goes into booking appointments and rescheduling appointments and managing DNAs. Online booking, which is perfectly routine for restaurants, opticians, all sorts of businesses, is still incredibly rare for radiology. It's very, very unusual to find a department that has managed this, and it would save such a lot of time for everyone, such a lot of resource, and also be much more convenient to patients. I really feel that we need to roll this out as much as we can, as quickly as possible. It's a win-win for everyone. And coming on now really to the synergy with Mike's community diagnostic hubs, we found that in the places where patients can attend community centres to have their imaging, this is hugely popular. It's much, much less stressful, much easier for parking. It's generally a much better experience for patients. We need to be able to support community diagnostic imaging with extended hours that is convenient for everyone, and also so patients can receive as much of their imaging as possible at the same time. It's not at all uncommon for patients who have several investigations to attend on successive days and travel very long distances to go for those investigations. So we really need to concentrate on that, and it should be quite possible. So moving on now from imaging acquisition to reporting. As we all know, there are standards for time in which imaging has to be acquired, the 6-week diagnostic standard, but that's not the case for reporting. So complex imaging is of no use to patients or clinicians unless it has a report that goes with it. So we do need to have national standards for reporting turnaround times, and that needs to be matched to the patient's pathway. So obviously the reporting turnaround time for an inpatient or an emergency department patient is much shorter than that for an outpatient. Now, such standards have been developed by the Imaging Transformation Team at NHSI and E, and we would urge that these are brought into the public domain as soon as possible. Although most of the trusts that we spoke to said that they would have trouble meeting national reporting standards because the reporting capacity gap is very large. The trusts all said that they would welcome having such standards so as they could benchmark themselves, they could plan for such standards, and generally manage their reporting capacity. So I think that would be a very popular move. I'm going to move on now and hand over to Giles, who's going to talk about maximising capacity.
Thanks very much, Kath. And just before while I share my screen there, thank you. I just wanted to, before I stop you through the recommendations on the section on maximising capacity, I just wanted to thank, on behalf of all our team, all those of you on the call who made us so welcome when we came to your departments. It was an uplifting experience to visit you all, and as I say, almost without exception, we were made incredibly welcome, and I would like to thank you for that, particularly the places that gave us coffee and Danish pastries. I won't name them, but they probably know who they are. So in terms of maximising capacity, there are 8 recommendations in this section. The first 3, no surprise, are related to workforce, which all of you know to be one of our fundamental problems in radiology. As Mike alluded to in his introduction, there is enormous variability in the use of different grades of staff to perform different tasks. There are places that have very well developed services, for example, for cannulation by assistant practitioners or helpers or care or assistants of one sort or another. There are places where radiographers are still cannulating patients in the room on the CT scanner, for example. Some of you will have seen our chart comparing the proportion of plain films reported by radiographers in different organisations, and the variation is from 0, none at all, up to something like 80%. So enormous variation. And without going into too much detail, one of our principles was highlighted at the end of the 4 there. Staff should be supported to work to the top of their licence. Time and again, we found that people had been trained with advanced practice skills, but were not able to actually use those skills and that training because they were being dragged off to do other things which were not at the top of their licence. And this is a real problem for us, and I think it would produce huge gains if we could address it. There's a major agenda required with the higher education institutions, HEE, the radiology academies and so on, as listed on the right there, to improve our recruitment and retention of staff at all grades. But a key to it is supporting staff, getting in staff at the lower bands and providing them with the tools and the training to advance through up to higher grades and provide the workforce of the future. And although I've focused a bit on assistant practitioners and radiographers there are also similarly activities required in the radiologist workforce. One of the key things we found, it is almost impossible to compare what radiologists do in different organisations at different times because there is no kind of acceptable benchmark for what a person does, how they spend their time. A reporting session in one trust might be completely different from a reporting session in another trust. There is definitely scope to harmonise this, and we're looking to work with the Royal College of Radiologists to do this. And also, of course, once you've done that for radiologists, well, why not reporting radiographers as well? The concept of the job plan, which exists in medical staff, really needs to be extended to those radiographers who take on advanced practice roles as well. I'm not going to say anything about MDTs. You'll be aware that MDTs have been the subject of recent national guidelines on streaming, and this perhaps one of the advantages of the COVID, or one of the positive spin-offs of the COVID outbreak, has been a focus on trying to make MDTs more efficient, and a lot of places are reporting that they have got more efficient through various mechanisms. Standardized protocols. We found that, for example, an MRI scan of the knee involves 2 or 3 sequences in one organisation, but 6 or 7 in another organisation. If you could actually start to rationalise that and produce a standard sort of protocol for a standard type of examination, give or take variation required for different equipment and so on, there are definitely efficiencies to be made there. IT, what can I say about IT under number 9? Some of the real heroes in our departments we found in the PACS teams. They are so hard pressed. They are up all night, in all weekend, trying to develop systems instead of just focusing on keeping the day-to-day work going. And they just can't do it all. They need help. Many places they didn't get nearly enough support from trust IT services or even sometimes from within their own departments. But real heroes, the PACS teams, and they need more help and more support to allow us all to work as efficiently as we possibly can. Something about capital equipment there, I won't go into that. Obviously, people have been asking already in the chat, what about finance? Who's going to pay for all this kind of thing? And we're waiting to hear at the moment in the comprehensive spending review a bit more information about how much and whether we're going to get extra funding for capital equipment. But definitely there are savings to be made and efficiencies to be made in joint procurement. Kath's already mentioned networks, and this is a big theme of ours, as well as of the Mike Richards report. And finally, just to show you are not forgotten, the interventional radiologists, there was absolutely no doubt on our visits that the places that manage this best and have proper dedicated day case facilities run by and for radiology services provide a much better, safer, more efficient, more productive service than places that rely on other units, other wards to harbour their patients, as it were. So we would strongly support dedicated day case facilities for interventional procedures. I'm going to stop there now and hand you over for the next session to our advisor, Elaine Quick. Thanks, Elaine.
Whilst I'm just sharing my screen, I would like to echo Giles's thanks to the Trust. It was an absolute privilege to join those visits, and I really welcomed the open discussions that happened between all grades of staff whilst we were doing that. Can you see my screen?
It's dark at the moment, Elaine.
Thank you.
Oh, no. It's not on screen show.
Is it now?
Yep. Yep.
Thank you. So we included a section in the report, making data work harder. And I mean, to do this, you have to have the data in the first place. Well, there's a wealth of radiology information out there. Sorry, I've just gone forward too fast. So the first lot of data we looked at was the DID data. There is absolutely nothing wrong with the collection of the DID data as it stands. They are collecting the right sort of activity data. However, what we did find when we've talked to trusts is sometimes people didn't actually know who was submitting that data. It wasn't being validated by the radiology departments, and it was a long time since that data collection was set up. I would say that people need to go back and just look over that and see whether they've got the right fields in the right places, because often there are things missing. For example, there's around 9% of the reports data that's not included in that even now, although the data collection is getting better. The national imaging data collection, which feeds into the model hospital, was our starting point for the GIRFT visits. And although we did say to Trust, this is only a starting point, this is the data that you've submitted, we were quite surprised that the number of trusts didn't actually recognise that data or say it was incorrect. And we know as we got further through the visits, it was becoming old data as well. So there was nothing there that was absolutely up to date. The National Imaging Data Collection also includes other data that's absolutely vital if you're going to look at your activity and capacity and demand. So it includes data on equipment, how old your equipment is, workforce data, and reporting data. As Giles has already said, who actually reports all the various images. Again, what we found with this collection is it relied on other people to submit some of that data, possibly not in radiology and possibly not understanding all the importance of it. So parts of it were often left blank because they didn't have the data, or they made a guess at what needed to go in there and just made that choice of what they were putting in. It's time consuming to collect all this data, and I do appreciate that because I've been on the other side of it, having to collect it myself. As I say, it needs several different sources to feed into it. We just got to get a bit smarter about what we are collecting and make sure it's relevant to people and how they're going to use it. The model hospital's brilliant for benchmarking yourself against national trusts, other trusts in your region, or other trusts that you know are of a similar size and activity to yours. So it's vital we actually get that data right in the first place. Finally, codes. Radiology codes was another thing. We often found that people were measuring things on either the patient activity coming through the door, the exam, or body parts. For example, the same CT examination on the same scanner in two different trusts. One would collect it as a thorax and abdomen. The next trust, it would be thorax, abdomen, pelvis. So 3 examinations rather than 2. What was right? It doesn't really matter as long as we standardise it. And finally, intervention. Giles has already mentioned intervention, and this we found was a really difficult area to get right in coding. It's had rapid expansion, and codes have tried to match that as they've gone along. But often an interventional radiology procedure will involve more than just one type of procedure, and perhaps more than one code needs to be added to this. And it's really hard to get outcome data from this. It's highly thought that doing an interventional radiology procedure saves on bed days, but we don't have any direct evidence of this. We need to get the data right to start with before we can start measuring this. And activity and capacity planning, if you don't get the data right going in, including all the other areas like your workforce, what radiologists are doing, what in PAs, you're not going to be able to plan your activity well. And the final thought, as Giles has said, to the PACS and RIS managers, we did find in several trusts that there was underinvestment in this. And if you don't get your RIS housekeeping data right from the start, it's going to be really difficult to match everything else up. I'm going to hand back to Kath now. Thank you.
Thanks, Elaine. Can you hear me now?
Yes.
And see my screen. Thank you. So yes, yet again, I'd just like to echo that big shout out for the PACS teams, the unsung heroes. I hope there are some on today. Now moving on to how are we going to manage this increasing demand? One of the things that we looked at when we went round in just a few pathways was how people, the huge variation in the way departments use their imaging. We specifically looked at the plain abdominal X-ray, the lumbar spine X-ray, and CTPA. The number of these examinations, it varies hugely across different trusts. And what that reflects is how people are using imaging in their clinical pathways. Now, I think we all agree, everybody agrees, that we need to do more imaging. Generally, the only way that imaging demand is going is up. So we're not saying that we're doing lots and lots of unnecessary tests, but we could be using our imaging better. And because we are so compromised in terms of capacity, we really need to make sure that when we are imaging patients, we're using the right imaging at a point in time when it's going to make the most difference to the patient's care. And the key to that is clinical pathways. So we need to make sure that the patients are on the right clinical pathway as well, which means that whoever is deciding which clinical pathway it is needs to be of sufficient clinical experience to do that. And also the pathways need to be in place. Well, there is a lot of evidence out there, and luckily we have the RCR's I refer evidence-based guidance on when to use imaging. This is used variably across the piece, but is a really valuable resource, and now is accompanied by a clinical decisions support software, which really would be very, very valuable if rolled out across trusts and CCGs. So we would very much support, and I know the transformation team are also very keen on this, so we'd very much support that. And another thing that you'll all be familiar with is when national guidance is produced, evidence-based national guidance, and we're so lucky to have NICE and other bodies producing this guidance, it usually suggests that more imaging takes place. And I mean, that's right. You know, it makes that we would support that. That's what we're here to do, is to look after patients. But I think we've all been on the end of guidance which we're suddenly expected to implement, and it's not clear to us how that's going to happen. So 700% increase in cardiac imaging, for instance, obviously the right thing to happen, but how can we do it? So we need to ensure that when these things happen, when this national guidance comes out, that some kind of anticipation of the effect that's going to have on radiology and how we're going to manage it takes place. And onto networks. Well, there's been a lot talked about networks, and there is documentation supporting the development of imaging networks in great detail from the imaging transformation team at NHSIE. And so I won't go into too much detail around that. We would definitely support the development of networks. It's definitely the way forward. But I'd just like to draw attention to two particular aspects of it, which we've already touched on. We've touched on intervention in many of the other, in some of the other sections. And this is particularly important when we're considering networks, because a large number of trusts don't have the capacity to provide the broad, all the intervention that we need. Sorry, all the intervention that we need, and many places have demonstrated that this can work well if a network is formed between interventional centres. Some other places, they haven't been successful here, and that results in considerable risk for patients. So I think that's really a priority when it comes to considering imaging networks. Another point that really became obvious to us when we were going round was the input that we could be maximising from our specialist hospitals. Our specialist hospitals are beacons of clinical excellence around the world. We're so lucky with that. And patients get referred to our specialist hospitals from all over the country. But one thing we did identify was that communication could be better. So those specialist hospitals could be communicating with the referring hospital better, and we could be facilitating better care closer to where the patients live. One other thing we've discussed already is the reporting capacity gap, and recommendation 17 is about trusts and networks having policy around the management and governance of reporting capacity. and costs of insourcing and outsourcing. Nearly all trusts use outsourcing. £120 million spent on outsourcing roughly per year. A lot of that is around imaging acquisition, but the reporting outsourcing bill is going up, particularly around out of hours. Most of these contracts are arranged locally. And because of partly because of some of the issues regarding data, which Elaine has highlighted, there is very little transparency, and it's very hard to compare what people are getting for their money. So we do need to really look into this, because there's an opportunity here to standardize to standardize those things and to ensure that we're getting the best value for money. Outsourcing is part of the future. It's not something that we're going to be able to stop. We absolutely depend on it, but we need to ensure that the governance and the value that we're getting for it is much more uniform, and also that some of the duplication around it is minimized. So there is quite a bit of work to do there. The other alternative that's been used very successfully in many trusts is insourcing, where our own reporting staff are paid to do extra sessions. Again, there is not a great deal of standardization around this. Some trusts have used it incredibly successfully, and it is part of the future. It's often preferred to outsourcing, and it has been really, really valuable. But again, the value for money that we're getting, and sometimes the governance, it does need to be examined and standardized. So we would urge particularly networks to look at this across the network. So that actually is the end of our recommendations for now. I can see there's lots of questions, and we'll try and address those as we're going along. I'd like now to welcome William Ramsden, Vice President of the Royal College of Radiologists, to produce a commentary for us on the RCR's response to our recommendations. Thank you.
Thank you, Kath. Can you see and hear me from where you are?
Yes, thank you.
Thank you. Well, I should first say it is an absolute pleasure to welcome the report and hear your commentary. We support it 100%. We think it is good for patients and good for radiology. It's a huge piece of work, and our congratulations are due to you, Giles, Elaine and Lucy, and all who worked so hard. It is a fantastic piece of work, and we are behind it 100%. Some of the things I would like to pick out is I really like the bit about improving the patient experience. That's so important to try and help patients come through our service quickly, but also feel comfortable in our hands and have their work done expeditiously, promptly, and not have to visit on multiple occasions. We like particularly the request for more space in departments to help this, and also we were very keen on your call for increased workforce and increased investment in equipment, which is something that we've been speaking about for quite some time. We were particularly keen on the making radiology more patient-centric. The idea of hot and cold areas at present must go forward as a good way to work, so that people who are scanned electively don't come into contact with people with things such as COVID. As a paediatric radiologist, just like you, I really like the bit about making services more child-friendly, and I would really endorse that. Separating children from adults in waiting rooms, making children feel more at ease, that is so important. Improving IT and equipment is another thing where we are definitely on the same page as you. We need to standardize IT and referral software and replace outdated systems to make everything more efficient. I heard what you said about networks just now, and I can only agree. I think networks are very strong, both for diagnostic work, so you can obtain a specialist opinion wherever you're imaged, and also for insourcing, as you mentioned at the end. And also for procedural work, such as interventional radiology, networks must help us give our patients a better service. Your mention of interventional radiology was also really welcome to us. we feel that IR is under a lot of pressure at present, and building its profile and building capacity must be a way to improve our services. Your comment that all radiology services should have access to dedicated facilities to admit and discharge day case patients for IR really chimed with our view, and we really hope that comes to pass. We were really pleased to see that some RCR initiatives were included in the report, particularly iRefer, which is a very big piece of work that we undertake to make sure that patients get the optimal test at the right time and referrers are well advised. We also like the mention of the radiology events and learning meetings, which are now increasingly being rolled out across the NHS. This will help people's learning and help spread best practice. We're very happy to support the GIRFT programme going forward with any of the data that we hold and that may help things in the future. This particularly applies to the census data when you look at workforce, and we can help the GIRFT programme show where the gaps are. We're also undertaking reporting standards work with SCORE and HEE in order to make sure that whoever reports things such as plain radiographs is working to the same high standard. And I hope that that piece of work chimes with what you're trying to do. So in summary, we think that it's quite an ambitious report, but it's doable and it is what we must all work to. We really look forward to working with GIRFT, with trusts and other national bodies in making it happen. Thanks very much for the opportunity to comment.
Thank you so much, William. Your support is so valuable to us. And now I'd like to move on to introduce Richard Evans, who is the CEO of the Society of Radiographers. Thank you so much, Richard, as well, for coming to speak.
Well, it's a great pleasure. I hope that everyone can hear me all right. And thanks ever so much for the opportunity to be here. As William's just said, the Society and College of Radiographers have also been involved in planning. Kath very kindly came to talk to us early on in talking about the process for this report and for the investigation beforehand. And we've been happy to be involved throughout and to welcome the report, which we support completely. Getting it right first time might sound like an obvious philosophy, but clinical professions know far too well that in many cases systems don't really support innovation. Good ideas sometimes are treated as suspect, and as a result we know that there's huge variation, as we've heard, in practice around the country and between trusts. Great practice at one centre is viewed with suspicion, even in close by hospitals, and the comment that you hear, oh, well, that wouldn't work here, is accepted as the final word too often. The great thing about the GIRFT programme, it seems to me, is that professionals themselves get to comment on all of that and get over it and really engage with the changes that they want to see in their services. No one goes to work to see a bad service, and we all want to see services improve. So I think the methodology of GIRFT, getting out there and talking to professionals and others in their workplaces and finding out what needs to change, is why you get a great result at the end, and that's why you see such great engagement by those professionals and their teams. So consequently, that's why the SOR has always supported the review process, and we're really glad to see the report now. The case studies inside the report, I think, are one of the highlights for me. They brilliantly illustrate the sort of good practice that really should be implemented everywhere. And I hope personally that managers, their teams and the Society of Radiographers representatives on the ground will see the report as an aid to business planning and influencing at the local level and at the regional levels, so that any changes required can be properly supported and resourced. It's one thing to have great ideas, it's quite another, as we all know, to get that supported locally. But a big national report like this, I think, gives some tools to managers to implement the ideas that they know that they want to make. No trust board should be able to dodge the responsibility they have to support their services in the best interests of patients. And I believe that this report goes a long way to provide that kind of impetus. I particularly like it that the report presents a world of service provision that staff in radiology service will actually recognise themselves. The methods, as I've said, employed by Kath and the team took them into departments, as we've heard. They talked to frontline staff and managers, and this is why the passion and commitment of frontline staff shines through in the report, in the best practice examples and in the case studies. We're particularly delighted that the report references the quality standard for imaging, the QSI. The GIRFT principles and those of QSI, it seems to me, are entirely complementary. Services that aspire to continuous improvement and measure their practice against professional standards, that sort of service, that sort of radiology service naturally wants to learn from others and in turn share their own good practice. The QSI, as everyone knows, I hope, is owned and updated regularly by the Royal College of Radiologists and the College of Radiographers. It is therefore a standard that is based on professional ethics, professional aspirations, and seeks continuous improvement of care and quality service delivery with the patient at the centre. So you can immediately see why the QSI and the GIRFT agendas are aligned. So it has been great to see that referenced in the report. We heard from Mike Richards earlier and his comments on the strong emphasis in his report focusing on workforce innovation and transformation. And so we're delighted to see that also in the GIRFT report mirrored. What we see in the joint visions as an absolute necessity for the future is a radically different attitude to skills mix in radiology services. If the GIRFT review is being written now, I would expect to see this even more strongly reflected, because as we know, we're talking about several months ago now that all this data was produced. So we should all be advocating lifelong learning and career progression through ongoing and funded CPD at all levels and for all staff groups. Skills mix needs to come of age, I think, and break away from the profession by profession approaches to become something much more integrated within any service. One of the commonly used phrases in the GIRFT report, we've already heard it, is we want to see professionals working at the top of their license. It's a really descriptive and punchy phrase, and I've used it a lot myself. However, I'm beginning to think it doesn't really do the job anymore, and maybe in future we can move on to something that is more inclusive. I think we're in danger of suggesting that individual team members reach a ceiling. They've reached the top, they have to stop in development terms. So the phrase doesn't do it for me anymore. It also doesn't really speak clearly to those members of the team who may not recognize licensing or regulation within their work experience, but there's capability across the team. We should be pushing for all members to be able to work in a way that makes the best use of capabilities, and that those capabilities can be further developed to meet the continuing needs of the service in which they work. So it's been great to be involved. Thank you, Kath and Giles and Elaine and Lucy. Fantastic work. Let's looking forward to the next review. When's that? And we'll join in and support as always. Thank you.
Thank you so much. And thanks to all of you for your support and advice along this process so far. It's clear to everyone that there is increasing focus on diagnostics, thanks in great part to Mike and his report. And it's also clear there are over 500 people now on this call. Diagnostics is of interest to people. And I think it's also clear that as an imaging community, both of our colleges and other bodies, we all have a clear vision of how we want to move forward, and we are in accordance as to that vision. It is now up to us and you all on this call to try and make it happen. After our experience of going around to 143 radiology departments in the country, I would just like to echo what the others have said. What amazing people. We were made so welcome. Any ideas about service improvement were lapped up by the radiology community. It was a really invigorating and humbling experience to meet you all. And if anybody can take these things forward, this community can. So now we'll try, we've got 10 minutes left, and we'll address some of the questions. We've tried to address some of them as we went along, but we've got lots and lots going on the chat. I could start by just, oh, Giles, have you got one? Have you got something to start?
I've fielded a number of questions, Kath, from which I'm actually going to address to Mike in the first instance, because quite a lot of people have said, well, this is all very well, but who's going to pay for it? When's the money coming through? So I thought I'd put that one to Mike.
Thanks, Giles. I saw those questions coming too as well, and I knew that it would come to me eventually. The answer is, first of all, we need to make the case, and I think we've both done that now. I have made the case to NHS England. We are waiting to see what happens through the so-called comprehensive spending review. Normally that's done for a 3-year period. We know it's only going to be 1 year at the moment because, quite obviously, there are lots of other things on the Chancellor's mind. My own view is I would really like to see us get going with some level of investment. It won't be what we want. I'm quite sure about that, given the circumstances. But we do need to. I would like to see some community diagnostic hubs getting up and running, because I think once we do that, we will demonstrate that the model works. It's just worth pointing out on that we're probably the only country in the developed world where the vast majority of our imaging is done in acute hospitals. And so can that be right? That, you know, and surely there are other ways of doing it. I think we can have flexibility about how we do it, but I'm certainly making the case for extra funding. But in the meantime, there's a lot of work going on, very good work in terms of recovery from the first wave of COVID, and now we're into the second wave. Actually, people are beginning to see what can be done with existing resources, and I welcome that. Doesn't mean that I'm not going to go on asking for more, I promise you.
Thank you. Thanks, Mike. And I thought that was a piece of fancy footwork, Giles, so I'm going to address one to William now. When will iRefer become universally available?
We are updating the iRefer guidelines continually now, and we have people who are actually paid to do this in the radiology community. The availability really depends on people who want to buy it and embed it in their systems. It's there to go, and some people have bought it and some people have embedded it, largely in Wales, Scotland and Northern Ireland. It's ready for England when you come and show us your money.
And again, I think there are plans to try and apply for funding for that. Other ones, anybody else? I've just caught one that's caught my eye from Rebecca about, is there an assumption that all trusts now operate electronic requesting? No, sadly, no. We've seen an awful lot that don't, and a lot of paper flying around. There is comment about that in our report, but we really need to move on from that. And I think this is also important when people talk about artificial intelligence, which I've also addressed one of the questions in the chat. Yes, AI is definitely part of the future, but at the moment we're not really ready for it. While we're still unable to request electronically, we're not quite ready for the complexity of AI. And what we need to work on is to make sure that we are ready to make use of some of those advantages and incredible work that's being done, a lot of it in this country.
If I could chip in now, Kath, a number of people have made the very good point in the chat and the questions about yes, supporting the principle of community diagnostics and whatever, but saying, doesn't that stretch our workforce even thinner, as it were? And I think if you read, and I would strongly recommend, if you haven't, have a look at Mike's report, because he does spell out quite clearly there that the move towards community diagnostic services absolutely requires more staff, basically. You know, we all know that. You can't have one person in more than one place at a time. So I think there is an absolute a clear requirement to train more people. I think what we have been working particularly with Richard and the College of Radiographers on is how we can make it easier to grow the workforce of the future, as it were. And I think there's quite a lot of innovative thinking in that space. Richard, do you want to come in at all on that point?
Yeah, thank you very much. As you say, innovative approaches around apprenticeships, particularly progression from assistant levels into radiography, is another big area to encourage, as well as developing more numbers through the traditional training routes. We've seen, because of COVID, the placement activity being a real challenge for people, but again, that's driven more innovation around virtual reality training, trying to get as much work done on on practical radiography before people arrive for their first time in a workplace. Interestingly, tried for years and years and very successfully in radiotherapy, just beginning to get that a little bit more embedded in radiography. So lots of innovation. That doesn't mean to say there isn't a huge challenge to create the kind of growth that we need to see, but you don't make the progress by wringing your hands about it. It's great to see that people are really getting stuck into to create change, to see change, to try things in different ways, and we're ready to support that at the SCOR.
Thank you, Richard. One, again, that has caught my eye here is Wood Hubs from Yasmina. Wood Hubs not minimise need for outsourcing. I think you're talking about networking, probably. I think networking would certainly even out. If we work in networks, we can even out some of the huge discrepancies in the reporting delays, but actually there is a capacity gap. So I think no matter how we work together, there will still be not enough reporting capacity, and we will still need to use outsourcing. That's my view. I don't know, what about anybody else? Got any views on that?
I'm not a radiologist, but I strongly suspect you're right, Kath, on that one. I do think that we also need, at the same time, to be using all the different tiers, as Richard was saying. What can we do with bringing people in at the lower end of the ladder, so that they can relieve some of the tasks, thereby allowing more people to take on advanced practitioner roles and then do some of the reporting there. We've got to be innovative. Part of the reason I believe in networks is not just the image sharing element of it, although that's very important, but it's actually within a network. I think that different departments can be comparing notes. You've given them the basis for doing that through this report, and I hope I have too. But actually, how often across a network are people saying, what are you doing that we could be doing? And I come back to the fact that if we did split emergency and elective, we could improve the efficiency of the emergency services, not necessarily for imaging, but we then make the case, and if we track the fact that lengths of stay are going down, and you've got a very nice case report from Northumbria on that in the report, saying, by having an emergency hospital, they have reduced their length of stay. We can all do that. And so there are efficiencies, and then we can make the case for the extra money coming into imaging generally.
Totally, and in support of your point about advanced practice and role extension, there is a lot of variation and very innovative work where people of lower bands can help those qualified staff to really make the best use of their skills, and there's lots and lots of very innovative examples that we've seen across the country. I think there's so much on the chat. We're just about out of time now. Don't worry, we will answer your questions. You will all get a reply, but I would just like to use the last couple of minutes to thank our panel for coming today, to thank all our participants for turning up today and taking an interest. I really hope that you have found this of some use, and please don't hesitate to contact us if you think we can help in any way. And I'd also finally like to say thank you to the GIRFT team for giving me this opportunity. I've absolutely loved it. So many people have made this possible for us, have really the people working on the report, people doing our communications. The GIRFT team has been amazing, and long may it continue. Don't know if anyone has any last points. We're just about to run out of time. No, thank you very much, everyone. Goodbye.
Thanks, Kath.